All set? Okay. Good morning, everyone. Thank you all for coming. So again, my name is Barry DeCoster. I'm the Crown Life Fellow in Bioethics here at U of L. The case I'm going to be talking about today begins from both some of my personal research in philosophy and bioethics and a sort of informal case that was brought to the Center for Ethics where I was working while at Michigan State. It was a after-the-fact question of what really happened, trying to sort out some of the issues going on, and did we do the right thing, or did the physician involved do the right thing. But the general theme is really going to be about issues regarding recording patient sexuality and sexual activity as part of medical charts. And this is important in part from my personal research, which is I've often been reading and writing on issues regarding the intersection of sexuality and medicine. So the healthcare specifically for gay, lesbian, bisexual, transgender folks. I'll usually abbreviate that, LGBT. So in the last 10 years, there's been a large increase in the number of ways in which LGBT health has been discussed in the biomedical literature and in direct healthcare literature. There's a growing increase in trying to address issues about sexuality in medicine and try to provide ethical care. But there's often sort of informal or unspecific directions about how to do this well or in an ethical consideration. So part of the work here is really trying to get more specific on how to provide caring and sympathetic care for patients. It was only in sort of the last year that the AMA has actually sort of come out as a public address and said addressing healthcare disparities for LGBT folks is going to be a primary consideration of the AMA. So there's ways in which this might be a way to further that conversation along. So to begin with, I want to think about what a sexual history is, when it's appropriate to take, what considerations we want to ask about what information to record, and then move on to ways in which gay and lesbian folks can feel more comfortable discussing their sexuality with their physicians. So to begin, this is the original case. It's a bit long, but bear with me. A patient was seen in a primary care clinic for a minor acute problem. Because his primary physician was not available that day, he was seen by a physician's assistant, or PA. The PA learned in taking the medical history that the patient was gay and included a brief note to that effect in the progress note. The problem was dealt with no special follow-up care. No special follow-up care was required. Excuse me. The PA's office note was sent as a matter of routine to the primary physician to be co-signed. The primary physician objected to the inclusion of the patient's sexual orientation in the note. He explained to the PA that the primary physician and the patient had agreed upon an unwritten contract that the sexual orientation would not be divulged in the medical records. The primary physician directed the PA to rewrite the note, but to leave out all mention of the patient's sexual orientation. The PA had concerns about making any alterations to the medical record, having been told that serious legal consequences would attach to such an action. At the same time, the PA felt an obligation to honor the patient's request regarding confidentiality of information and to protect the relationship between the patient and the primary physician. Also, as it turned out, being gay did not seem in any way medically related to the particular health problems the patient had that day. So a number of important questions that I work on in sort of a larger piece of this, a piece that I'm working with to write up with Tom Tomlinson from Michigan State University. Some of the questions that I won't cover today, but we may be, if there's time in the Q&A, you might want to ask about things about who owns the medical chart and the information contained within it. What should that sort of doctor-PA relationship be like here? You know, sort of who has the authority and the final say about the chart? And what are the legal ramifications are there to changing the medical chart? The questions that I will be talking about today are these two. The first, what concepts and categories should be considered in taking a sexual history? So what is the language and what are these ideas that we really want to focus on as being the most helpful in taking a sexual history? And the second, if the sexual history is a conversation between the physician and the patient about a wide range of activities and identities, what aspects of that conversation should actually go into the recorded chart, right? What are the pieces of that conversation that we should be writing down and why? So to begin, what concepts about sexuality and identity are useful here. The first point that I want to talk about here, and one of the major mistakes I think happened for the PEA in this case, is the failure to separate sexual identity from sexual activity. Now, in the literature regarding sexual history taking, there's a fair amount of push to try and get more clinicians to take sexual histories. And they range in the suggestions of what questions to ask, what information to record. But generally, they talk about a number of things, including how sexual identity is different from sexual activity. What happened in this case was a label of sexual identity became the primary focus. So these might be labels such as heterosexual, homosexual, or gay, lesbian, bisexual. Where the problem arises is in large part leaving the conversation at this level, which is what happened in this case. The move to fail to kind of continue the conversation prevents one from understanding why these labels have more than sort of a social meaning. In many cases, the primary moral problem will be something that we make assumptions about what these labels mean to us or what they mean to the patient. So for the instance of gay men, right, immediately associating the phrase gay or the identity of gay to has anal sex, when we know sort of somewhere between 20 and 25% of men, gay men, report that they have never or rarely ever have anal sex. For lesbians, it's usually a problem of how to identify relationships prior or current with men, or questions about children. So the label of lesbian in a medical chart, and when I'm talking about these are often sort of scribbled at the, somewhere on the chart. Just sort of, in the case that I presented to you, it was sort of almost an afterthought. It was written at the top in one of the margins, homosexual. So there's not a conversation that's recorded here. It's a label of sorts. Okay. Where I've been thinking about these labels, there are also other people who have suggested additional or alternative labels, and some of these are attempts to label not just identity but sexual activity. So this may be sort of the move to labels like MSM, WS, WM, these clumsy things, but MSM standing for men who have sex with other men, WS, WM might be a more activities-based approach to describing the identity of bisexual, so a woman who has sex with both women and men. These are, in one sense, an attempt to articulate why labels of identity are dangerous. They make assumptions. So instead, they're attempts to record sexual activity. The problem being for both of these is neither one feels just about right. For sexual identity labels, these may be the language that physicians and patients are most comfortable with, right? We use the language of straight, gay, lesbian, and more in a widespread way than we do the language of MSM. These are not comfortable labels for us. The other issue is that even with identifying something like MSM, the labels work, again, to prevent further conversations. They're recorded at this point, and often we sort of fail to take the further step of saying, why is a continued conversation about sexual activity, getting to the specifics, what are the specific health risks or considerations for this patient, what kind of information does this patient need? There have generally been a discussion about how when physicians get to this level, they end the sexual history taking. So they need some sort of label, a way to identify this patient for themselves, for the records, possibly to share with other clinicians. But the sexual history taking often sort of stops rather than going on as a conversation like other aspects of medical history taking, where the label ends up being what I'm calling a conversation stopper. Rather than going on and asking questions about, do you, the patient, have further questions for me? What sort of information can I provide to you? How are you comfortable with the positions with the position as a social identity that you're in? Are you out in your workplace? Do you feel that you have sufficient sexual health information available to you? Okay. One of the other interesting notes about the limited research out there on sexual history taking is that clinicians take sexual histories in a rather sporadic way. Only about 20% of clinicians say that they usually or always take a sexual history from their patients. So in general, although it's recommended that all patients have a sexual history taken for them, most physicians are being inconsistent about when they're taking them. Generally, they aren't asking such questions, or when they are, they're a rather brief or sketchy history. The other point being that sexual histories are most often taken once patients self-identify as being either gay, lesbian, or bisexual. So physicians are in large part taking a limited number of sexual histories, and they're taking it from a very small population, those patients who already are out to their physicians. What I'm interested in part I was talking about is discussing why sexual history taking generally is an important and relevant thing for a widespread component, why it's relevant to all patients, and also thinking about why it's important to take sexual histories in a consistent and fair basis. So you might ask, if we are only taking sexual histories from a small portion of the population, in one sense, there's two ways that this may be either both inconsistent and sort of unfair to general populations. The first being, if gay and lesbian patients are the ones being asked about their sexual histories more often, this is a group that historically has been disadvantaged within the medical community, but they're also a community that wants to sort of discuss, if you ask in the service, this is a group that is trying to get better information from their physicians. This is a group that wants to talk about their sexuality and the ramifications this has upon their health. But in one sense, you have patients navigating whether or not they feel safe enough to become out to their patients or to their physicians, and only then are they getting sort of detailed histories taken. The other interesting thing is, if there are significant, and I think there are, important reasons to take detailed sexual histories, you have the majority of the population that is primarily heterosexual, but then also the majority of the 80% of patients who are not being asked for sexual histories. These people are failing to receive the benefits of a sexual history process. Which leads us to sort of the next question I wanted to ask about. If the sexual history taking is a conversation between the patient and the physician, what aspects of this conversation should be recorded? We can also ask, what purposes is this information doing for us? And what are the goals of taking a sexual history? So I've started thinking about a list of the considerations. Who benefits from taking sexual history, and which ways do we benefit from having a record, like a written record, of information about sexual identity and sexual activities? The first two are actually very closely related, serving as a memory aid for the clinician involved, and also sharing information with other clinicians within the same practice. So in this case, a number of physicians have reported to me that they often try and take sexual histories, and when they do, and they feel the sort of worry about whether or not privacy of the patient may be exposed, they've developed not just these labels, but sort of secret or internal labels about identifying sexual identity or sexual activities. So often this will be some sort of codes, and these have varied dramatically, but it might be something. One physician said she recorded a W that is circled, and that was her indication, both to her and her fellow clinicians, to say that when dealing with this patient, there's something about sexuality that should be discussed with the patient further. It's something that we don't feel comfortable recording here and now, but go on and try and ask that when you think it's relevant. So rather than sort of worry about the label gay or lesbian may be disclosed to third parties. An interesting attempt to balance it, but I still worry that sort of even at that level, the secret code works as a label for gay or lesbian in her practice, and it's actually preventing further conversations, although it may be protecting that patient's privacy. Other indications or other resources where we would like information recorded about patient sexuality. information sometimes for legal purposes, especially if we're worried about issues about whether or not taking proper sexual histories is a part of good managed care. Records for reimbursement, and also data for research purposes. Now, if the benefit here is directly for the patient, it seems the first two of these considerations are most directly going to benefit patient care. The third may be important for other issues, but the sort of ways in which gay and lesbian folks have most often described their worries about privacy and discrimination, they have most noted that their biggest fear is that the information will be leaked to some sort of outside party, whether that be insurance or made publicly available. So if there's a way to ensure privacy, they're okay generally with sharing information with their physicians, but they're most distrustful when it comes to the idea of sharing that information to outside parties. Okay. Let's see. In discussing further issues about privacy regarding sexual history taking, one of the important things to remember, though, is that I've been talking about sexual history taking first as a conversation and only then as a part of a written document. So keeping the communication processes separated may be helpful here. If the oral conversation is something gay and lesbian folks may be amenable to, if they're agreeing to have these conversations with their physicians, then the question may then become really more about which aspects of the conversation are we going to write down. It's at the written portion of this where I think the biggest risk to privacy comes into play. The second question we can ask is, in what way should we allow patients' anxieties, whether it be about sort of generally being out to physicians or about having that information made public to third parties, what way should we allow patients' anxieties to limit the information that that physicians can record in medical charts? Here, keeping this in mind, I've started thinking about clinical suggestions for this problem. There won't be, I'm guessing, any sort of definitive, no categorical suggestion that it will fit. There's going to be a wide range of issues here, and it's generally going to be a balance between that care for the patient and keeping their privacy issues and their fears of losing privacy, keeping that balance with the medically indicated information, why this information may be important. So generally Tom and I, have been thinking about, first and foremost, be transparent in the conversation. Talking with patients about why the physician thinks this information may be medically relevant, especially in the case that we began with, right? In the afterthought, the information was found to be not very relevant to the case at hand. Lots of times, though, this won't be so easily distinguished. When you have issues that there are emergencies, or when you're trying to understand how to record sexual histories as part of sort of a long-term piece of care, what becomes unclear is we still have to balance that risk of privacy versus the medically benefit of having this information recorded and then also shared between clinicians in a practice. Being consistent. Part of our hope here is that consistency, will make taking sexual histories not something that is only a product of dealing with gay, lesbian, bisexual patients, or the majority of. We also, the records, or the little bit of research that's out there, says physicians who take sexual histories on a general basis become much more comfortable in talking about sexuality and sexual identity with their patients. So in being consistent, taking sexual histories as a matter of routine rather than as the aberration in a conversation with patients, hopefully we'll get past part of physicians' anxieties in dealing with gay, lesbian, bisexual patients, and also dealing with sexuality in general. Patients are often reporting too, they notice that one of the key features that when they decide to come out to their physicians is that sense of comfortability that the physician is expressing. So if a physician is noting that he or she seems comfortable in talking about sexuality, patients are more likely to disclose, and they're more likely to be fully honest and ask questions from their physician. Oh, went too far. Finally, the third part being here, trying to foresee and prevent future misunderstandings. one of the biggest misunderstandings that we've noted in our work is that way in which labels of sexuality, especially in written documentation, are more likely to be taken up by others and misconstrued. So although the physician may have had long and detailed conversations with their patients about the complexities of identity and sexual activity, what we want to know is trying to prevent that record from portraying incorrect information when it's taken up by others. So this may especially be important in clinical settings where physicians rarely see the same patient, but they're within a practice. How to have that information translate over in meaningful ways that prevent the misunderstandings that may have been in the original case. And with that, I think that's the end of my presentation. So, thank you. And excuse me.
In the last Gein's lecture, Art Kaplan presented an argument about embryonic stem cell research. The argument that he presented basically said it's defensible as long as one is willing to accept in vitro fertilization. If you've accepted IVF, then you've already accepted all the moral claims necessary in order to defend stem cell research. He said, in fact, if we can accept embryo loss for the service of certain goals, and there meaning in vitro, then embryonic stem cell research may be a goal where we can accept that loss as well. And since many or most people do in fact hold that in vitro fertilizations are morally acceptable, this seems like a good approach to take, particularly for public policy. But when I asked him how he would respond to those who would argue that embryos, because of their potential, are morally similar to adult humans and thus perhaps would be willing to reject in vitro fertilization, he expressed a couple of things. I mean, first of all, he said he doubted that that was going to be a terribly persuasive argument on its merits, but it was otherwise willing to say if there were some holdouts that were willing to reject in vitro fertilization, then he was willing to more or less let that be. It simply wasn't a politically feasible position, and thus was one that he figured was safe to ignore. I suspect he's right, that the general public would agree that any argument that said in vitro fertilization is immoral is probably not going to carry much weight. But I think the problem that's raised here has to be addressed a little bit more carefully for at least two reasons. First, just practically speaking, I don't think the argument is quite as much of a political non-starter as Kaplan suggests. The George W. Bush administration has made a fair amount of hay out of promoting embryo adoptions, where you adopt an embryo and carry it to term and raise it as your child, despite the fact that there have been just virtually none of these, and they're not going to make any dent in the number of in vitro embryos available. More importantly, I think a number of the people who are currently on and have previously been on the President's Council on Bioethics have argued more or less explicitly that the moral value of embryos is equivalent to that of adult human beings. So whether or not this notion is being consistently employed or not, this notion is driving some policy in the United States. The second reason, though, that I think we should address this issue is that it depends upon a confusion. Embryonic stem cell research is often defined as a pro-life issue, and therefore if you are pro-life, i.e. opposed to abortion, you must therefore also be opposed to embryonic stem cell research. And this is a mistake. I think this is an erroneous claim. A settled position against abortion does not necessarily direct you to reject embryonic stem cell research. And the reason for that is that there is a difference between the embryos used in embryonic stem cell research and the embryos and fetuses involved in the abortion debate. And that difference can make stem cell research acceptable, even if one holds that abortion is impermissible. Now, politically, I think this is an apt move, since these two debates, embryonic stem cell research and abortion, are tied together in many people's minds. But I think it's also a logical extension of Kaplan's argument, and that's why I phrase this as, here's a challenge to Art Kaplan and how he should respond to it. The opponents of Kaplan's position that I'm addressing here hold that we ought not do any research where that involves the destruction of a human embryo. And the rationale for this is that, morally speaking, the embryos are roughly equivalent to adult human beings. Since obviously they're very different in, virtually every fashion, this argument is typically made in terms of potential. Because an embryo is potentially an adult human being, it should have similar moral status. That argument is made often along the following lines, and this is Alfonso Gomez Lobo, who is on the President's Council, makes this argument. And he says, after I was conceived, I had the active potentiality to develop into the kind of adult I am today. Not everything was predetermined. There are, random factors that play into it. But he says, my genome was endowed with something akin to a program that made me become a human being and not a cat, male and not female, and so on. Heredity already was present within me. This is the argument, in other words, that says that this kind of argument depends upon. The potential is there from conception. So any human embryo has a similar potential from conception on to become an adult human. And thus it ought to be treated as having substantially the same moral standing as an adult human. That's the argument, what I call the argument from embryonic value here. It's basically an argument that says, because of potential, embryos ought to be treated as morally equivalent to normal adult humans. Now, this argument seems to motivate a number of things, but most importantly, this argument seems to motivate President Bush's rejection of most forms of embryonic stem cell research, but acceptance of a few. That is, he says explicitly that all human life is something precious to be protected, and that the government should not sanction or encourage further destruction of human embryos, but allows for research where, as he says, the life or death decision has already been made. By that he means embryonic stem cell research on stem cell lines that were started before he made a speech about it in early August 2001. Keep that in the back of your mind, because that phrase or that notion is going to come back, perhaps even come back to haunt him in about 5 minutes. But the argument here, and this fundamental argument that embryos are important because of potential, implies that all embryos are the same in terms of their potential. And all embryos are relatively equal to normal adult humans. And I don't believe that argument's going to hold up. It's readily apparent, I think, to most people that not all uses of the word potential are the same, and that there are morally relevant differences in potentialities. So an embryo has the potential to become a normal adult human, but then again, so does a skin cell, as long as you clone it. And, we destroy skin cells by the thousands every day. If just having potential to become a normal adult human is what grants something moral standing, then skin cells have moral standing, and that's not going to make any sense. So what I'm going to argue is that not all embryos are the same. That, in fact, an in vitro embryo is more analogous to a clonable somatic cell and less analogous to an in vivo embryo. And therefore, the respective potentialities of the two embryos are very different, and different in ways that will become morally important. And realize the importance of this. If an in vitro embryo is in fact morally similar to a clonable somatic cell, then since it is absurd to treat all somatic cells as having the same moral standing as adult human beings, it would be similarly absurd to treat all in vitro embryos as having that standing. So this is a critically important distinction here, because it allows you to separate the abortion debate, implanted embryos, from the debate about in vitro embryos. Wait, let me go back. The idea here is this. An in vivo embryo, or an implanted embryo, in utero embryo, you can phrase it lots of different ways, is pretty clearly not morally similar to a clonable somatic cell in some important ways. The upshot of which is probably this. If you do nothing, an implanted embryo will normally develop into an infant, and then things will progress from there. Obviously, that's not entirely true. If you do nothing, an infant will die, and so on and so forth. That's not the key concept. The idea is that the potential of the embryo and fetus, really, since we're talking about abortion, most of the time we're talking about fetuses and not embryos. The potential is ongoing, and it is developing actively as we speak. But that's the distinction, the potentiality that seems to be relevantly important. And as we'll see, the same is not true about an in vitro embryo. Nor, of course, is it true about a somatic cell that hasn't yet been cloned. So there's a big difference between implanted embryos and somatic cells, but the question is, what about in vitro embryos? Now, I think the analogy between an in vitro embryo and a somatic cell becomes a lot more apt in a way that I think can be seen clearly from a statement by R.M. Hare writing about embryos, mostly in terms of abortion. And he says, the potentiality of an embryo to develop into someone who, let's just say for short, is a grown person, is important because if it does, that grown person will benefit. Or more importantly, it is important because preservation of embryos is important because if they are preserved, they will turn into grown people. Well, that's true about most implanted embryos, in vivo embryos. If they are preserved, they will turn into grown people. But it's not true, and this is the key concept I want to point to, it is not true about most in vitro embryos. There's an important distinction, in other words, between embryos that are implanted and embryos that are in vitro. In fact, actually, I'm going to say there are two relevant distinctions between most in vitro embryos and all implanted embryos. Well, the first one is that most in vitro embryos are in fact frozen. But the second one is that all in vitro embryos are not yet implanted. And I'm going to say that both of these are in fact important. And they are important precisely because they affect the potentiality of the embryos in question. And this matters then because if their potential is different, then they need not and should not be treated in the same fashion. So let me take a look at both of these distinctions. I think both of them matter, but either one independently is sufficient to distinguish between in vitro and in vivo embryos. A frozen embryo is one that is not developing at the time it is frozen. It will not become an adult human being without significant external interference. And for that reason, it reminds you quite a bit of a somatic cell that will not become an adult human being without significant external interference. The embryo, the frozen embryo, will not grow, develop, or change unless it is affected by some external factor, in this case, thawing process. So it is not dynamic in the words that Gomez-Lobo uses to describe the active potential of embryos. It isn't. Its developmental process is, in fact, completely suspended. So a frozen embryo is not, in Hare's words, actively developing towards anything. And this gives grounds, I think, to say that the frozen embryo is very similar to a somatic cell. Without an external activator, either cloning or thawing, you have no development, no potential. This would give grounds to argue that frozen embryos have a different potential from implanted embryos. But you could at this point respond, okay, but maybe then the problem is that you froze the embryo in the first place. And therefore, what's immoral is to freeze an embryo because that is what disrupts the potentiality of the embryo. I don't think this line of argument is going to work. But before we get to that, it's worth noting that even if you work along the lines of this line, if you try to make this argument and say the problem was freezing, and therefore you cannot freeze in vitro embryos, then in that case, according to the rationale given by the President for his embryonic stem cell policy, we should be able to use frozen embryos for stem cell research. Because in that case, remember I said keep this in the back of your mind, well, if the life or death decision is made when you freeze an embryo, then any frozen embryo should be acceptable for use under the President's stem cell research policy. So practically speaking, if you say the problem is freezing embryos, that makes a huge difference in what the stem cell research policy is. But more importantly, I think, it's difficult to see how you could make an argument that it's freezing embryos and then thawing them again, that is somehow morally impermissible. I mean, that's precisely the point. If you thaw them again, how could freezing them be somehow a problem? That would mean that temporarily suspending the potential of an object and then returning it to it later would be morally equivalent to destroying the potential of that object, which just seems to be strange. Furthermore, since the implication of these arguments against embryonic stem cell research is that destruction of an embryo is morally comparable to murder, it'd be quite possible to have an embryo that was frozen, thawed, implanted, grown into an adult human being, and yet somehow murdered long before it was ever born. And I'm not trying to say they would be required to say that, but I'm not sure how you'd get out of it. And this sort of bizarreness of making moral sense out of the moral status of this now living adult just points out the difficulties of trying to say freezing embryos is the problem. But quite apart from those kinds of theoretical concerns, lies the quite practical point that the potential of the unfrozen in vitro embryo is still more similar to a somatic cell than it is to an in vivo embryo. It's not true of in vitro embryos, even before freezing, that if they are preserved, they will turn into grown people, to use Hare's phrase. Indeed, as one in vitro fertilization clinic puts it pretty clearly, here are your options, or one of your options, for handling your unimplanted embryos. Among other things, you may freeze them and so on, but you may also allow the embryos to develop in the laboratory until they perish, at which point they will be disposed of. And this occurs within about 6 to 8 days after egg collection. In other words, an unfrozen in vitro embryo isn't going to turn into an adult without significant external intervention. It is developing towards perhaps the blastocyst stage, but that's about it. It's got about 6 to 8 days of development. So if potential of an embryo is important, the potential of even an unfrozen in vitro embryo is not the same as the potential of an in vivo embryo. You've got, I mean, just think about it, all the things that you have to do in order to take an in vitro embryo and turn it into a normal adult human. You've got to collect it carefully, you've got to insert it through a fairly delicate medical procedure into a woman's uterus, which has to be carefully prepared ahead of time. And by the way, you have to have a woman's uterus available. So it just takes a lot of effort, a fair chunk of luck before this in vitro fertilization, and more to the point, an external action has to be performed on the embryo in order to develop it into anything. So the active potential of an embryo in an in vitro fertilization facility is very different from that of an already implanted embryo. Now you might try to argue against this, as I think Alfonso Gomez-Lobo does, to say that there's an important difference between a somatic cell and an embryo, regardless of where that embryo is. And that's to say that all embryos have active genetic potentiality. The somatic cell's potential has been switched off. I mean, this is the well-known feature of non-germ cells, that though they have the genetic potential to be any cell in the body, they actually won't turn into any cell in the body. Skin cells have been turned into skin cells, despite the fact that they have the genetic component to all of them, to all cells in the body. So this seems to be a plausible response, and it's one that has been given. But it seems to blur an important distinction between genetic potentiality and this notion of active, changing, dynamic potentiality. They're not the same. And the way that you can see that genetic potential and active potential are not the same is by looking at a somatic cell to be cloned, an in vitro cell, and an in vitro embryo, and an in vivo embryo. The somatic cell is not actively developing towards the end of becoming an adult human, and will not without great external interventions. But it does have the genetic potential to do so, whether or not it actually ever does develop into anything. The same thing, however, is true of an in vitro embryo. It has the genetic potential to develop into a normal adult human, but it will not without significant external effort. The external factors are different. One's implantation, the other one is cloning, but each one makes the potentiality of the cell, which is already there in its genetics, active. So if I am correct, this means that the potential of embryos in pregnant women is not the same as the potential of frozen embryos being considered for use in embryonic stem cell research. And consequently, the potentiality argument works differently for stem cell research and abortion. And therefore, one might be able to reasonably hold that embryonic stem cell research is permissible, even if you hold that abortion is wrong because of the potentiality of the implanted embryo. If potentiality is important at all, and that's a big if, but we'll leave that here. If potentiality is important at all, the potential of in vitro embryos is much more, how should we say, merely potential and much less actual than is the potential of in vivo embryos. And that's how Art Kaplan should respond, I think, to that challenge.
We'll now have your response from Dr. Paulson.
Thank you. I have no pictures, but I do appreciate my colleagues, Dr. Hansen and Dr. DeCoster, and the careful way in which they have articulated the problems that they are addressing. And I propose to address their presentations simultaneously, and then to pose issues beyond that, taking this opportunity for myself to respond to Art Kaplan. Is there a light down here? I get a lot of microphones, but is there a light? I have trouble enough reading without trying it in the dark.
Oh, well, that's it, but I don't know if we have control over it up here. There you go.
Hey, let there be light. Thank you. I appreciate Dr. DeCoster's careful attention to issues regarding privacy and confidentiality with special regard to LGBT persons. I appreciate his efforts in that this is raising some consciousness, at least, that important issues have been overlooked, sometimes in the clinical context, failing to appreciate that those who are LGBT persons have special needs with regard to the confidentiality of information. It's highly personal and very important socially, perhaps even economically and otherwise to them. He also correctly, I think, relates these questions to issues in sexuality as such. Not all of us are totally comfortable talking about sex. Issues in sexuality still belong to a long list of taboo subjects in America, to some degree at least. And many of us have carried that heritage, either from Puritanism or from Orthodox Catholicism, that made us pretty uncomfortable with our own sexuality. It's just not something we talk about. And that carries over into the way we do clinical judgments. So the awkwardness in the environment of dealing with these subjects in general carries over in special ways to dealing with these topics with regard to LGBT persons who have been the special objects of persecution, of hate, of suspicion in this society. So they have certain reasons to be paranoid, just as the clinician and other persons may have reasons to be perhaps overly aggressive or even prurient in the way they pose their questions. Well, homophobia is not dead. We've seen from the demonstrations that certain churches are leading, even at some of the funerals for men who have died, men and women who have died in Iraq. So it is still here. Well, I have certain questions about what Dr. Coster has said, and some of those relate to the case itself. I wonder, for instance, why there was no alert given to the physician attendant by the attending physician before he dealt with the patient. If there is some agreement already reached, the assistant needs to know that. And that may be an issue in professionalism or communication or however that is put, but that needs to be communicated so as to avoid those invisible traps into which we often walk for lack of ignorance, not because of meanness or hostility toward the patient. We just don't know that the arrangement is already made. A second question I had is, what are these false assumptions on the part of the physician assistant that is stated but not spelled out? Dr. DeCoster might do us the favor of saying what they were. It might enhance our own level of awareness, and thus we also not engage in that. If I were to guess about what those were, that would perhaps perpetuate the problem. Guessing is always hazardous at best and sometimes very injurious. Now, I agree also with Barry in saying that there is no easy resolution of the tension between various interests at stake. It underscores the issues of trust and truth-telling, of privacy and confidentiality in the clinical context. It also reminds us of the lack of control that physicians and hospitals have over vital and crucial, highly personal information. Once it gets into the airwaves, it goes where it will, and there's no way to recollect it. It's rather like spread butter. It's gone. It's spread. So lack of control. Now, another thing to say is that patient confidentiality is not an absolute ethical obligation on the part of the physician. I suppose we all agree on that to one degree or the other. It is what the philosophers refer to as a prima facie duty. It is a very important duty, but there are others that are more important. And one of those being patient best interests. We might, as has been suggested by Robert Veitch, scuttle the idea of confidentiality because so many people have to have access to the records. What do you mean, confidential records? But it's in the patient's best interest. There are a lot of people who are involved in the best health care of the patient. There's no way in that context and setting to keep absolute confidentiality. You can be concerned about it, but your concern will not buy you absolute privacy. Now, second, as to the relevance of the questions that are to be asked, in general, I think we can say that they are fair and reasonable expectations, and these should be explained with and discussed with the patient. What are the expectations? One of the great dilemmas in communication, where we're dealing with marriages or romantic relationships in general, or the patient-physician relationship, is the difference in expectations. I expect one thing, they're expecting something else, and we don't talk about it. We just assume that we're on the same page about expectations, which is very problematic. It's important to talk about what I am expecting and what you may see and have as a difference of opinion. Expectations bump up against one another, and when they work out differently, there's disappointment, maybe even hostility, or somebody gets injured or deprived of the sort of best care to which they deserve. Well, one good reason physicians need to know about risky behaviors is because risky behavior has to do with our health. That's not a question particular to those who are LGBT. It refers also to those of us who are heterosexual. There are a lot of diseases out there that might be caught during sexual activity, and they need to be talked about. And how else is the physician to figure out what's going on with us unless we talk about the behaviors in which we've been engaged? That may be an important clue to the thrush that we're presented with. Well, now we have something to talk about. Well, DeCoster's point is that negotiating information is to be recorded in the chart is true to a point. The question is, if you're not going to record it, what does the next physician do? Just simply work in ignorance, the vacuum created by the fact someone did not record some important information? And in our context here, because there is such a seriatim of physicians treating patients, you simply cannot go back to ground zero and start all over again with the questions pertinent to this particular patient's health care. So it needs to be recorded for the benefit of those who come after us. The question is, what might rightly or ethically be omitted? The rule is, it seems to me, any information of importance to diagnosing the patient's condition or monitoring the patient's treatment over time needs to be in the chart. Now, that there may be some risks with that sort of candor in the chart is to be granted. But we all take risks in our sexual behaviors and in our social engagements. And we cannot expect everybody to keep that because they are somehow ethically obliged on our behalf. There are risks in that. There are risks in being treated. So that belongs to the clinical setting, it seems to me. As to Art Kaplan and Stephen Hansen with regard to pre-embryos, which is my preferred term to speak of those which are in vitro, Dr. Hansen is right to question Kaplan's notion that our in vitro fertilization policy is sufficient to give political traction to embryo stem cell research. The Bush approach has strong support by people in positions of influence and the religious right, however. By the religious right, I mean this coalition of religious groups that range all the way from the most notable leaders in that, the National Council of Catholic Bishops and the Southern Baptist Convention, ardent evangelicals. Those are the identifiable leaders in the political support upon which Mr. Bush depends. And they have really been coming through for him, and vice versa. Well, the Bush approach depends upon people who are in positions of influence and power. It doesn't have to be many of them. In our elections, they're so close now that only a 5% differential in a group's vote will swing an election. Mr. Bush knows that. He follows the advice of his leaders in Washington that says if he gets 80% of the vote of the religious right, he will win any election. He learned that in Texas. Well, he pitches his message to his constituency, and that constituency is that 5% vote. Now, that's the reason why the potentiality argument is not going to fly. It's not going to have any political traction whatever. And the reasons are that has already been morphed into a different argument. They're not even talking about potentiality anymore. They reversed the poles. It is now a person with potential, not an embryo with potential to become a person. Notice the language. So if we're still talking about potentialities, they've left us behind by 5 or 10 years in this debate. And they're certainly not going to go back and revisit that issue. Another point is that Dr. Hansen is correct in saying that there are some who want abortion legally prohibited but still favor embryo stem cell research. A notable example of that is Orrin Hatch. He does want to make abortion illegal, but he supports ESR. because his family has experienced certain difficulties that might benefit from embryo stem cell research. Now, here's the issue. The main core of the religious right opposes both legalized abortion and embryo stem cell research with equal vehemence and belligerence. Yes, there are nice distinctions that can be made between pre-embryos used in ESR and embryos related to abortion. But that distinction is only one reason why some support ESR but not abortion. And again, I refer to Orrin Hatch. It's only one reason. There's a cluster of considerations that add up to their support and or opposition. The reasons are far more complex than any single consideration, and especially that of the potentiality argument. Even so, what is true theoretically does not and will not make ESR acceptable politically to those who oppose embryo stem cell research, though many of us would prefer that it be otherwise. I happen to believe that both abortion and embryo stem cell research should be legally available. But for those who oppose it, the issue is one of what we refer to as the seamless garment approach. That wherever you find human DNA, you have the moral equivalent of a person that is to be preserved against any sort of violative action. The argument that we've seen recently in the hearings with Mr. Alito with regard to, whether or not we should ban partial birth abortion, and they want to know, well, how many women are going to die if we should ban partial birth abortion? And it came down to a question of, well, how many women can die and it still be acceptable to ban partial birth abortion? Well, those who oppose ESR and oppose abortion believe that even the loss of one is too high a moral price to pay for whatever benefits there might be accrued from embryo stem cell research. You can't kill even one of them for the sake of these numbers of people who might benefit from the research. That is paired with an argument that you can find among those who oppose it, such as Mylander, who says that we have no obligation in medicine to cure all diseases, especially if curing it depends upon sacrificing embryos. Well, you get those two arguments together and you see more of the seamless garment. Furthermore, if the in vitro fertilization pre-embryos are to be discarded, it is better to let them thaw and die in their mind, that is the opponent's mind, than to kill them intentionally in order to experiment with them. It is the intentionality of the action that's the problem. Accidentally, you may lose hundreds of thousands, which is what we're facing where in vitro fertilization is concerned. But that is better than allowing anybody to intentionally and knowingly kill even one, for whatever good reason. Now, intentional killing is always worse than discarding because it constitutes direct and willful killing. So goes the argument supported by the President. I think Dr. Hansen is right that the argument will hold up to philosophical or religious scrutiny, but it is still held by the administration, and strongly so, because that's where his people want him to be. The relationship of logic to ethics by those who oppose embryo stem cell research is tenuous at best. Logic flies out of the window when emotions come to the surface. Emotions that appeal to fears and hates will win out every time over reasonable, sweet, reasonable logic. Well, there are other grounds that need to be noted, it seems to me, that need to be addressed in this debate. Part of the problem is that we have succumbed to the framing approach of the right to life or the anti-abortion, anti-embryo stem cell research people. They frame it in terms of killing a person. We need to change that to say, what does this say about the woman? We're simply allowing it to take place that the norm of the parity between an adult person and an embryo is to be accepted without question. I find that to be atrocious argumentation on logical, or in my tradition, biblical or moral grounds. I find it extremely problematic, even totally unsupportable, to say that an embryo has the same moral value as a woman. Women are the ones who are losing rights in our efforts to protect embryos. Well, how many women? Is it okay to sacrifice for the sake of saying, but we never kill an embryo? That is an issue that has not been sufficiently ferreted out, I think. The anti-woman arguments of both the Vatican document, Respect for Human Life, and other documents, and the Southern Baptist Convention's 2000 Baptist Faith and Message, spells out this notion of the ontological status of the woman being subsidiary to the man and also to the pre-embryo. The reason being, the embryo is innocent. The woman is guilty. She has sinned willfully, knowingly, and intentionally, and thus takes on a secondary aspect to the embryo that is sinless. Now, I find that so problematic as to make you want to jump up and down and yell a few obscenities. But that's where the argument is. Well, another is the religious liberty argument. If you press them as to why is an embryo of such moral value, they will finally say, as John Noonan admitted, that it has a soul. God has provided something out of the mysterious workings of God that we cannot fathom and scientifically cannot discover, but it's there, it is asserted, and that something is soul. Well, now we really are in deep water. How do you argue against the soul? It is non-verifiable, it is non-falsifiable. You can believe it if you will, but it is hardly a scientific notion. But instead of relying upon the embryologists who tell us that even the potentiality of the fertilized ovum in the womb is hardly even probable that they will come to term. Estimates are that anywhere from 50 to 70% of those do not come to term. Well, the religious liberty argument then needs to be explored further, as well as the subordination of woman. I mentioned one last one without amplification, and that is the attack on science. Since when can we say to science that thus far can you come but no further? I'm a student of religious history, and it seems to me that we're right back in the days of Galileo, when the church stood up and said, you cannot publish your findings because that will do harm to faith. Oh, wait a minute. Now we take all that for granted. It took 400 years for the church to apologize for that. Galileo's findings had to be published posthumously. And finally there was a half-hearted apology saying there were mistakes made on both sides. No. A Catholic theologian stood up and said, no, not on both sides. Galileo was right. It was the church that was wrong. And it was time that was said that way. Well, on what grounds? Do we use a religious argument, something drawn from metaphysics, to say that you cannot experiment with this? I say no. Go on the basis of science and allow science to research with those pre-embryos that are sure to be lost. Thank you. Time for discussion.
Why don't you moderate the questions, but just hand the microphone back and forth for what questions that are being raised. So we will now take questions for all three. Dr. Foster, Dr. Hansen, and Dr. Simmons. Questions to be had?
I'll lay this here, young man. Elizabeth, yes. Question, Dr. Tobin.
I have a question about the sexuality issue. In the 1960s, the issue was brought up to a medical school class relating to, the advice columnist, Gail Van Buren,
Dear Abby.
and she often said to people who are homosexuals who are having sexual problems to go talk it over with their doctors. The medical school class said, well, why we? We have no better insight into any of these things than anybody else. We don't have this. Given the social attitude toward gay, lesbian, bisexual, transgender people, why do we think that doctors will not bring their social, religious, cultural biases to the discussion and really add to the problem of the patient?
So repeat the question, please, Marie.
Okay, so in part it was, there's a long tradition, especially of thinking that physicians may be the person to go to if you're having sort of sexual problems at a large scale. And what's to prevent physicians from bringing their own social baggage, issues about discrimination or discomfort to the conversation with patients, right? Are patients better off for having those conversations with their doctors? And I think that my response would be, yes, physicians will bring their own issues with it. In part, there may be moral considerations that they may have a hard time getting over. But what I'm hoping, and the literature seems to back this, is that as physicians discuss this with patients, they get over certain issues, that discomfort quickly. And the more they repeat those conversations, the better, the more comfortable they are in having those conversations with other patients. I think we often have physicians who, for whatever reason, are discussing things that they may have personal or moral disagreements with. Sexuality may be one, but lots of other things, you know, drug use, the in vitro reproductive kind of technologies. Right? You can discuss these things in a clinical sense, and then you can also step back, you as a physician, and say, here's how I may feel about this personally. But I don't think there's anything in one sense particular or unique about discussing sexuality that should prevent patients from being able to discuss this with their physicians, unless you're thinking about something that I'm missing. Oh.
May I add to that?
Sure.
But would you agree that there is a lack of education about issues in sexuality almost across the board in the United States, and that physicians are also in need of, of further insights about the kinds of sexual problems that they face?
Yes, I would agree with that, and that seems to be changing in the last 50 years dramatically, right? This is becoming the age of will and grace. So the kids who are now, and the future docs of America will grow up with a very different discussion than maybe what the doctors that I've been seeing have had. But that's one of those things that I think is changing, and it's changing for the benefit for all.
Other questions?
Yes, question here.
When you discuss whether or not to put the information on sexuality in the chart, it seems that, I'm the privacy officer at UofL, and so it seems like physicians would have this huge struggle in talking with the patient, having the patient's concerns about privacy, but also wanting to put the information in for clinical care, and cautioning against the physician implying to the patient that it might not be further disclosed because of both the issues you raised about the record going to multiple places, but also the provision under HIPAA that says if I make a request and you agree to it, then you are obligated to honor it. And so if the physician has said to the patient it won't be further disclosed, they've now attached some legal obligations to that even go beyond the discussion of ethics and privacy. And I'm just curious for responses on, helping physicians handle that, because that seems to be a significant struggle.
One of the goals I had, so going further, but the question was about further complications around privacy and whether or not HIPAA and other regulations actually make this a legal issue, not just moral and political, right? And thinking, does this agreement to keep certain information private, does this obligate the physician to things they may not wish to be obligated to? Part of what I've found interesting in thinking about sexual histories as a specific example, but the sort of greater conversation about what gets recorded in medical charts, is the amount to which I think generally both myself and the population at large has no idea what goes into their medical charts, right? What's getting recorded. And what I'm hoping is, in part, that the issue of sexuality, but other issues will get discussed, and navigating that conversation about what does get recorded. Why is it important to have this in here? Because I think plenty of patients will be willing to run the risk of having the information in the chart, but all they know about why that's important is the doctor wants it there, and then on the negative side, the patient is fearful of exposure. I think what I'm hoping would happen would be there'd be some sort of back and forth there, an educational process of the physician first explaining the realities of the situation, how confidentiality is almost a reality, a myth, right? Or it's a gabby confidentiality. And then the importance for why this may benefit the patient in the long run, right? Why is it important for the patient to have this, to run that risk? And I think most times patients will be willing to, I would say, run the risk of having the information recorded. I also think it doesn't obligate the physician to do anything he or she isn't comfortable with. If the physician doesn't feel like he or she can live up to that sort of obligation, they can have that conversation up front and say, I may not be the doctor for you. I may need to refer you to someone else who can kind of either hold the confidentiality and the means that you're asking for, or at least I can't live up to the request that you're making. So how are we going to navigate that?
Very good question. Yes.
Here's one.
Last question.
Question. Before I came, I reviewed the Kaplan video that you all provided, so I didn't know what you all were presenting. And he talked about in the hospital that's on fire, you have like 2 rooms. One room has frozen embryos, the other room has babies. So he said nobody would disagree. Let's save the babies. So as a statistician, I'm always trying to get people to get away from that kind of thing. So I thought, let's just line everybody in the world in this hospital that's on fire. We have the frozen embryos, we have the premature babies, we have the babies, we have the children, we have the young people, then we have the middle-aged people, then we have the old people, we have the dying people. So who are we going to say? Kind of see, what is it we're trying to preserve here? You talk about potentiality of life. Well, the really old people have already lived 70 years, and their potentiality is 1.
Let's make that 90. How about that?
Not save the people that have already lived, because their potentiality is complete. They're 1. Because obviously, we make decisions all the time. People whose lives are shortened and their quality of life is going to be terrible. Turn off the machine. They even write that. I even have a statement saying, turn off the machine in my will. So, to me, this idea of just saying, well, yes or no, is really like we need to get our act together as humans. Like, what is it that we're trying to preserve? Is there a comment on it?
Right. The question came off of an example that Art Kaplan talked about, where he says, if there were a fire and you could save either babies or embryos from an in vitro fertilization lab, it's obvious that you would save the infants. And the question was, forget the dichotomy, we really kind of need to line people up and say, what exactly is it that we're trying to preserve? So we'll not only just distinguish between embryos and infants, but also between infants and older people, people who are terminally ill, people who aren't, and so on. While I sympathize in some sense with your wanting to get away from simple dichotomies, I think this one is a different one for the following reason. If somebody were to be in a fire and deciding whether or not to save a petri dish full of embryos or an infant from the pediatric care section, to even stop and think about it would just show a fundamental misunderstanding of what's really important in the situation. And that wouldn't be the case if you were saying, well, should I save a child who hasn't had much life yet, or should I save an older person who has only maybe, say, 10, 20 years left of likely life? That's a legitimate question. I don't know what the answer would we want to come up with is, but that's a legitimate question in a way that do I save an embryo or do I save an infant isn't. Right, it just shows a fundamental misunderstanding of what's really morally important in the situation to ask, do I save an embryo or an infant, in a way that actually asking the question, do I save the older person or the younger person, doesn't show a misunderstanding, but rather points, as you suggest, to a question that we haven't addressed, but it's a legitimate question. Do you want to add something to that, Paul?
Yeah, a little bit to that. Yeah. To us, that may seem to be a perfectly logical and acceptable conclusion, but to some of those who are in this movement that so adamantly opposes ESR don't count on their saving you before they'd save a bundle of Petri dish embryos. That is their strong commitment, at least on the surface. And they have pursued that through every avenue of legal help that they can achieve. And they've made significant gains, in part because of the indifference, maybe the unbelief of the vast majority of citizens in this society. Fully 80% of Americans support embryonic stem cell research, Democrats and Republicans and independents. Now, why then is there a prohibition on embryo stem cell research from the top? It's an issue of power, not truth, an issue of the perpetuation of a particularist point of view, not the will of the people. And I find that rather deplorable.
And with that, we're going to close our session and thank both of you for excellent presentations and an excellent response. Thank you very much for attending.